Thank you very much, Mariam, for the kind introduction. Thank you for staying till this moment. That's very kind of you to stay till now. So now we're going to change the whole subject to angioedema. So we'll have 4 sessions. So I'm just going to set the scene of angioedema. And then following that, Dr. Ravi and Dr. Iman are going to be discussing in details the biological advances in the treatment of hereditary angioedema, and then end up with our lovely patient to kind of talk their experience from hereditary angioedema. So these are my disclosure. None for today's session. So I'm going to be concentrating on 3 main subjects. I'm going to be very brief, hopefully, and not take too much time. So this is going to be reviewing the clinical presentation of various angioedema and when should we suspect angioedema. That's number 1. And number 2, we summarize the current and emerging diagnostic tests on different types of angioedema, and then just briefly about the management approach, but then the advances I will leave it for Dr. Iman and Ravi. So the clinical presentation of angioedema is classic. When you see it, you'll never forget it. So usually I've got this patient with localized asymmetrical swelling because of the extravasation of the fluid in the deep subcutaneous and submucosa. So when you have different type of angioedema, you're going to be thinking about the first question to start with, is it really angioedema or not? Because there are a lot of condition that can present as angioedema, or the patient will tell you, I have got angioedema, I've got a swelling, and loss of referral we see, sometimes not really linked to angioedema, can be linked to a totally different disease. When we think about causes of angioedema, the longest, by far, this is not an exhaustive list. It's a very long, very many causes of angioedema. But when we come to hereditary angioedema, we've got certain things we need to think about. So I've gone 3 quick cases to kind of think which angioedema is which. Is this hereditary or is that a different type of angioedema? All my patients from my previous hospital when I was in Manchester. So this is a 45-year-old male. He came to you, the referral was early morning swelling. He went to ED department and being treated there. This one is a 62-year-old woman. Is that clear? A 62-year-old woman, and the main problem, she keep coming to ED department with upper airway swellings, angioedema. And this one, loss of hand peripheral angioedema, loss of swellings there, and she had a childhood history as well. So keep these 3 cases in your mind. So we go back to basics. Obviously, when we come to angioedema, the first thing is this purely angioedema, or is that something else with angioedema? Well, let's talk about just isolated angioedema. The first question will be, how is the pattern of angioedema? Is it something like a sudden onset, or is that something like slowly going on over time? And I think that's the key, because that will be differentiating our 2 main family, the histaminergic and non-histaminergic angioedema. And as we know, the majority of the angioedema come to our clinics are histamine or mast cell mediated angioedema. The bradykinin-mediated angioedema is quite rare. So this is one of the lovely Italian studies early on in 2006, I think it was 7. And when they presented here, out of their patients with isolated angioedema, almost 40% were just purely histaminergic. So you can see here, the histaminergic is a common one. But why we worry about angioedema? Because angioedema or hereditary angioedema can be lethal, can kill patient, and that's why we worry about. This is one of the very old data by a great group in Germany, and basically showing the number and the causes of death in patients with hereditary angioedema. And that's exactly why we worry about angioedema and why we worry about hereditary angioedema, and why, as immunologists, we need to go outside there and tell the world about angioedema and when to suspect hereditary angioedema. So this is the main test. Whenever we go to any clinics, as you all do, when you go and teaching to any other non-immunologist, the test is clear and it's quite easy to differentiate the different types of angioedema. So we've got the key here is type 1 hereditary angioedema. So type 1 and type 2, the key is C4. Complement C4 is always low, as we all know, and that's commonly in type 1 and type 2. If you've got everything low, that's your type 1, which is, we know is more than 75% of the hereditary angioedema. If only the function is low, then we're thinking about type 2, which is only around 15% of hereditary angioedema. The problem is those group of patients with hereditary angioedema from the history, but everything else is normal. So this is a lovely diagram from the latest international guideline, and it's kind of self-explanatory. From the tests we do, C level, function, and C4, if everything low, dealing with type 1, if only the C function, C1 inhibitor function low, we're dealing with type 2. When we come to the normal C1 inhibitor level and function, then we can be dividing into two main groups. Are we dealing with patients with a family history of hereditary or suspected hereditary angioedema or not? And here when the genetic testing started. Now, maybe 10 years ago, we only know about factor 12 as the main cause of normal C1 inhibitor hereditary angioedema, but now we know about so many causes of hereditary angioedema. And obviously, I'm not going to go through this at this time, but just remember the three main pathways. So you've got the complement pathway, but as well you've got the contact activation system and the fibrinolysis system. And any defect in all these factors can be a cause of a normal C1 inhibitor hereditary angioedema. So that's why there's a lot of genetic panels at the moment keep going. So we know about factor 12, we know about plasminogen, we know about the angiopoietin, but there's a lot of other genetic testing, and there's a group of a normal C1 inhibitor with no gene identified. And I think that's where the struggle is. Now, when we talk about biomarker in hereditary angioedema, biomarker can be diagnostic, biomarker can be prognostic, biomarker can be predictive biomarkers. And the biomarkers, I think that's what the move forward. And I'm sure our colleagues, when they talk about hereditary angioedema advances in biologics, we only know these biomarkers because these can be helping diagnosing hereditary angioedema, especially in the patient with a normal C1 inhibitor, and as well can be important in response to therapy or predictive. Now, I'm not going to go through all these tests, but there's a lot currently happening from measuring the phospholipase to bradykinin to others, but the problem is all in research perspective and obviously none at the moment. So the key thing here is when we come with a patient with angioedema, majority of the patient, 40 to 50% are histaminergic. Those 30% or 25%, which we're thinking is C1 inhibitor mediated or bradykinin mediated, if we couldn't find anything, sometimes we need to think about doing the test again. And I think that's the most important message we want to kind of get around. We suspect it's hereditary angioedema. We've done the test, everything is normal, but then they still keep coming. So sometimes you need to do a test when they have an attack. And we've done that many times, and we actually identify low C4, for example, if you manage to get C4, and that's what give us the answer. Sometimes you have to try a treatment, see if that's going to work on them or not. And that's again a trial, obviously, that's led by immunologists, and reassess. And of course, the history is the key. So I think the key message from setting the scene today is history in hereditary angioedema. That's kind of the key to diagnose hereditary angioedema. When I talk about diagnosis, we have got the C4 as a key for any patient coming to emergency department or coming to any other clinics. But then the rest of the investigation will be depends on the history, and we try to time our investigation so we can get the right patient. Most of the isolated angioedema is histaminergic isolated angioedema. So most of them are still tryptase. They respond to all the mast cell treatment is already been explained by my previous colleague. Clinical follow-up is the key, and when to time our investigation is the key. And I think our message as immunologists is extremely difficult to get and educate people about a rare disease that potentially can be lethal. Thank you very much. I'll stop here.